Welcome to our Parkinson's discussion. This is Kim Sanders. She is the program manager, and I will let her say a few words.
I'm Kim. I'm with the American Parkinson's Disease Association. I'm the program manager there. So me and my teammate Amanda, better? Amanda is out, so I am filling in for her today, so I apologize now. But we as a team, we work in our program, so it's our exercise, our support groups, any educational programs that we have in the community. That's kind of all of our scope of practice over at the office. We're not too far down the road over there, Chesterfield Parkway West. So I'll start by basically just telling you, we're going to talk a little bit about the essentials of Parkinson's. I was told some of you have Parkinson's or may have Parkinson's.
You can start with just...
Okay. But I just want to make sure that I'm touching on all of your possible questions. So if there's any specific questions off the top of your head that I can make sure that I'm going to touch on this presentation, we'll kind of talk about that now, and then when I get started, I'll touch through those as we go. Does anybody have any questions off the top of your head?
No. How do you know you have it?
Ooh, there you go.
Okay, so we'll talk a little bit about symptoms, things like that, how to find out what the doctors will look for, and that kind of stuff. Any other questions off the top of your heads? Nope. Yes, sir.
Diet.
Yes, got that covered. It's in here.
Diet. Okay.
Yep.
With the cardio.
Yep, got that. Perfect. Anything else? Yes, ma'am?
Are there specific exercises that are more beneficial than others?
Yep, we'll talk about that as well. Yes, ma'am.
Could you repeat questions
Yep.
as people ask them?
Yep, so the first one was, how do I know I have Parkinson's? So we're going to touch on that. The second one is diet, and how can diet affect my medication? So we'll talk about that. And then the last one was exercise, and what is important about exercise with Parkinson's, and are there exercises that are better than others? Yes, ma'am.
How do you get it?
How do you get Parkinson's? So the next question, and we'll touch on that too in the research that's being done to figure that out. Anything else? Yes, sir.
They're going to come up with a cure.
They're working on it. We'll talk a little bit about research as well, so we'll go into that. So I got the go-ahead. I'm going to go ahead and get started with the presentation. Ask questions, raise hands as we go. If I talk too fast, tell me to slow down. I'm known for that. So we'll get started. So the overview is, what is Parkinson's disease? We'll go over symptoms, statistics, risk factors, treatments, how to manage your Parkinson's, and how your caregivers can assist you, and then some further resources that we at the APDA can assist you with. So strength and optimism and hope and progress. There's tremendous progress in understanding what is Parkinson's disease. It's highly individualized from person to person, and not all that we'll discuss today is going to be relevant to each of you. But you do have control over managing your Parkinson's. So one saying that they have is that if you meet someone with Parkinson's, you've met one person with Parkinson's, because every single person presents differently, which also makes it difficult for doctors to come up with the cure we're looking for. So just a little background about Parkinson's disease. So it was first written by James Parkinson in 1817. He wrote this essay called The Shaking Palsy. And then from there, further research was done, and then they came up with the Parkinson's disease. And then what is Parkinson's disease? So it is a disorder of the nervous system. It can affect the person's abilities to perform activities. It causes motor and non-motor symptoms, and the laundry list of those we'll go over here shortly. Symptoms are due to the loss of a brain chemical called dopamine, and then the dopamine is stored in the substantia nigra and regulates the smooth, coordinated movements. So right over here inside our brain, that's where the dopamine is stored. And when we lose that over time, our movements get rigid and stiff, and it makes it harder for us to complete daily tasks. So a diagnosis is made based on signs and symptoms and a doctor's observation of how you move. And sometimes reactions to medications can be used as well. So difficulties with diagnoses may occur because there's not a definite diagnostic procedure. So there's no testing. You can't go in and have an MRI or a CT scan. That's just part of the process of figuring out you have Parkinson's. And they typically use those to rule out the other neurological disorders or diseases. An MRI scan, a DAT scan, and blood work can be used to rule those other tests out. So, they'll look at MS and ALS and Parkinson's, and they kind of, many of them have similar symptoms, but those can be found with those tests, and Parkinson's cannot. So typically, what they'll do at your doctor's office, they have you walk down the hallway, which most people are like, I do that every day. Why is that something that you're looking at? And typically with Parkinson's, one side of our body is more affected than the other, and that's how it starts. So typically when you're walking, one arm or both arms may not swing, and that's what the doctors are looking at. Other things they're looking at is that tremor. So everyone thinks Parkinson's, oh yeah, that's that tremor disease. There's so much more to it than that, but sometimes that's where it starts. So as we go into some symptoms, like I said, it's a pretty long laundry list here shortly, but we'll talk about the tremors. So that's at rest. Some people have what they call an essential tremor. That's where if you're going to reach for something, that's when your hand gets shaky. This is more, I'm just sitting here and I have that tremor in my hand and I can't get it to stop. Sometimes it's in our feet. The rigidity is the stiffness. So, as we sit around and our bodies get stiff, this is all the time. This is when we're trying to move. This is when we're trying to get up out of a seat or take steps. Everything is more robotic and stiff. Bradykinesia is slowness. So those with Parkinson's can have slower movements. We start to shuffle our feet a lot more. We might not move our arms as much when we're walking. And then postural instability, so trouble with balance and posture. People with Parkinson's fall a lot, so it's important to focus on safety as well. So we use this image as the motor symptoms and the non-motor symptoms. So our motor symptoms are kind of what we see on the outside. It's what everybody that we're talking to, our friends, our family, that's what they notice. And then the non-motor symptoms are all inside, and a lot of people, you can't see them from the naked eye. So there's a lot more of those. So as we go through, we'll kind of touch on each little section of symptoms. So we'll start with the non-motor symptoms. Sensory, we have loss of smell. That's been a huge one in the topics the last couple years as COVID came through and everybody lost their smell. Loss of smell is something that can also be a sign of Parkinson's. Visual problems, so mild double vision, or if you're, as you're looking at something, you see kind of two of it. Most people, as we get older, we have visual problems. We have macular degeneration or cataracts. So that's just something that you really wouldn't think about because as we get older, that tends to happen naturally. Some of the motor symptoms would be dystonia or muscle cramps. And then we have small cramped handwriting. So a lot of people with Parkinson's realize writing just gets difficult. It gets really small. So they might start out real normal and fill in the lines, and then it gets really small and illegible. We call the next thing masked faces. So little facial expression, almost like they're looking through you, or they're not happy, or they're not really interested in what you're talking about, where deep down there's still a person in there, there's still a personality. It's just as Parkinson's progresses, it's all muscles. So if you're thinking about all the muscles in our faces, those tend to relax and not move as much. And then freezing of gait is the last one, and that's our walking problem. So they have found that with Parkinson's, you can have what's called freezing of gait, and it's literally where your feet are glued to the ground and it's hard to get going. Most of the time that happens in smaller spaces, so in crowded rooms or through doorways, you'll have a person, they just stop. And so it's important to kind of figure out what's causing that. Physical therapists will use like a visual whether it be tape on the ground or walking to a metronome to keep that beat so you're stepping on the beat. And that kind of keeps your brain thinking about getting your feet going. And then we'll talk a little bit about speech and swallow. So about 90% of people with Parkinson's have a soft voice. So we focus a lot. There's a huge program in the speech world called Loud Crowd. There's another one called Speak Out. And it's working on strengthening those muscles in our voice to keep projecting. We also, with that, come swallowing difficulties. We have so many muscles that get our food from the front of our mouths to the back of our mouths down into our stomachs. And that's, as we think about our muscles slowing down, we're not thinking about swallowing as much. And that can also cause excess saliva. It's not that you're creating more saliva, you're just not swallowing as much as we naturally would. There's also gastrointestinal problems, so constipation, and this can be something from childhood. Working with your doctor is important on that because there's so many complications that can come with constipation, but that is a sign of Parkinson's. And then weight loss. That can be triggered to either loss of appetite, or maybe you're not moving as much, or just an overall change in your body. That's something we keep an eye out for and talk with our doctors. And then we talk about sleep. So there's the REM sleep disorder. It's insomnia, acting out our dreams. Many people with Parkinson's will have very vivid nightmares, to some points that we've had folks that will talk about how it's scary and it's put them in dangerous situations. And that typically happens about 38 to 50% later in the disease process. And then obviously fatigue. When we're having to do so much more to get our bodies moving, it makes us that much more tired. There's also mood, depression, anxiety, apathy, the no will to want to do anything, basically. So what we talk about a lot with Parkinson's is how important it is to move our bodies, which is difficult when you don't want to do anything. So that's where the caregiver comes in, and the importance of the caregiver in keeping them motivated, keeping those hobbies going, because depression and anxiety can set in after that, and then you're kind of fighting an uphill battle. Cognition, so slowed thinking or word finding can be difficult. Executive functioning, so multitasking, planning, problem solving, your overall judgment, especially with safety, can become an issue. And then a few others. Orthostatic hypotension, so that is all related to blood pressure. So you know that feeling when you go from laying down to sitting up, or sitting to standing, and you get dizzy and you feel like you're gonna pass out? That's all based on our heart, so that can be part of Parkinson's, to where we want to worry about our safety when we're going from laying down to sitting, or sitting to standing. We want to do that nice and slow. There's also temperature regulation, so being very cold or very hot, and it's kind of all over the spectrum. And then urinary frequency and urgency. We all know as we get older, that's an everyday issue for most of us. So that's just one more thing to add to the laundry list of Parkinson's. Yes, ma'am.
Could you define visual, spatial?
Yes, so visual spatial abilities is basically if you're looking in a space, you're able to know exactly where something is, so you're not running into it. So right here, there's a step right here. Knowing that that's there. So it's almost like it's part of your depth perception as well. So that way it's more for safety. Does that answer your question?
Yeah,
Okay.
I think you skipped it.
Oh, sorry. There's a lot. So then we'll go into a little bit of statistics. So in the US, approximately 1 million cases of Parkinson's are diagnosed, and they're planning on 1.3 million by the year 2030. There's about 90,000 new cases each year, and this all just changed. It used to be 60,000 as of last year. They've done a bunch of research. It's jumped 30,000 people a year, and someone is diagnosed every 6 minutes. The average onset age is 60. Anything under 50 is considered young onset Parkinson's, so your Michael J. Fox, And typically with young onset, your disease progresses a little bit faster. The later on in life, when you have your Parkinson's diagnosis, things tend to slow down a little bit and your disease progresses a little bit slower. Approximately 10% of PD cases develop before the age of 50, and men are 50% more likely to get Parkinson's than women. So someone asked about environmental factors, risk factors, things like that. So this is kind of what they're looking at as far as research on where does Parkinson's come from? Why do we get Parkinson's? So with genetics, there's more than 20 genes that have been identified as potentially contributing to Parkinson's disease. However, most people with PD don't have that mutation in any of the identified genes. And so that may contribute to the PD gene not being discoverable yet. But having a first-degree relative with Parkinson's modestly increases a person's risk of developing PD. And I'll go through the next couple slides and I'll tell you my thought on that, because we're going to talk about environmental factors. So you think about if you have somebody that is a relative, you might have grown up with them. You might have lived in the same area as them. So if it is environmental, then you've all been breathing the same air, drinking the same water, eating the same food from the land. So environmental toxins, such as pesticides and solvents, may increase the risk of Parkinson's. So those that have grown up on farms or have been kind of more living in rural areas tend to have Parkinson's more than the others. Traumatic brain injuries also increase the risk of Parkinson's. So if we do damage to our brains and the dopamine stored in our brains, then that could cause that increased risk. And then environmental factors may interact with particular genes to affect the PD risks. So this map, it's a little blurry up here, but this is overall incidences of Parkinson's in the United States. So the dark purple is going to be more cases, and then the lighter green is going to be more, or less prevalent, sorry. So when you look at this, it's, you typically look at like the bigger cities and things like that that have more people. There's more cases of Parkinson's. And then you kind of go up into more of like the mountainous rural areas and, there's more land, there's more people kind of spread out among that area. So then we'll talk about Parkinson's treatments. So we have medication, we have exercise, and then we have DBS or deep brain stimulation. And we'll kind of go through each of those. So medication may relieve or decrease the symptoms of Parkinson's, and the goal is to get the right dose and tolerance of your medication. So proper ongoing adjustments of your medication is key to effective treatment, and that can change over time. Some people start out, they don't want to take their medicine at all, so they kind of just let the disease take its course. They start maybe changing their diet a little bit, doing a little bit more exercise, and that can help. Other folks that jump right into taking their medication, it might be 1 or 2 pills 3 times a day, and over time, you typically, your body gets a little bit more used to what your medication is, or your symptoms get a little bit worse, and then they'll add in another pill or another dose. Responses to the medication vary from person to person, so it's really important to talk to your doctors about how your body is reacting, whether it be, I'm just not feeling good after I take my medication, or my what we call off times, where you're just not moving as good. That might change a little bit as well. And a person may take a combination of medications to control a given symptom, because different medications have different mechanisms of action. So you might take your Parkinson's medication, and your carbidopa-levodopa is your Parkinson's medication, but then you have other symptoms. Maybe you have the constipation, or you have the anxiety. It's important to keep up with your doctors and make sure that you're taking something for each of those symptoms, so that way you can treat it. Because at the end of the day, the Parkinson's medication is only treating your tremors and your movement. So I'll kind of briefly touch on this a little bit. So our carbidopa-levodopa, or Cinnamon as some people call it, is our main Parkinson's medication. It's been that way for years. They have not changed what it is. I believe, I want to say 83 years is what else is sticking in my head, but it's been a very long time that they haven't changed it at all. They've just changed how you can get it into your body. So now there is an intestinal gel, there's like an inhaler that you can take, there's your regular pills, and then there's extended release. So they've added that in for people in the evening time. They can take your extended release and that gets them through the nighttime. These are all some other types of Parkinson's medications. Many of them are not here in the United States, so they kind of work. Different countries have different medications that they use or names for them. So then we'll get into our rehab therapies. So our physical therapy, our occupational therapy, and our speech therapy. So physical therapy is going to improve your balance, your walking, your strength. They'll help you with an exercise program and keep you moving. Your speech therapy is there for your voice, so we talked to how your voice can get soft. So speech therapy can work on those vocal exercises and strengthening those muscles. And then swallowing difficulties. So we talked a little bit about that and making sure that what we're putting in our bodies is safe to swallow, whether our muscles are too weak. There's ways to adapt our diet and what we take just to make that safer. And then occupational therapy for improving our fine motor skills, our mental strategies, so those word finding cues, things like that. Home safety and then daily living. So how are we getting around our house? Is our environment safe? Do we have throw rugs on the floor that are tripping hazards? Are we getting in and out of the shower safe? Those are all things that occupational therapy will work on. And then the last thing is our DBS. Some people want to hear about this, some people could care less because it is considered a brain surgery. So basically what happens is this is called our lead, and this gets put down into where the dopamine is stored. And then it's almost like a little monitor. It's like almost like a pacemaker. Some people have them on both sides. Some people will just get them on one side to work on the affected side. And it's basically a rechargeable battery, and that will keep you moving. I will tell you, from my experience of working with people with Parkinson's, I would say it's about a 50-50. Some people that have it have absolutely had great results, and they are so grateful they've done it, and then other people will come in and say, I really was expecting a lot more, but at the end of the day, it's a brain surgery. It can be scary. You would hope that something like that would give you the greatest effects, and it doesn't always. So that's something that if you are interested, the doctor has to do a lot of testing and making sure that cognitively that you will do okay having the surgery, but also that your body is strong enough to do so. And then we'll talk a little bit about managing our Parkinson's. So things we talk about: exercise, nutrition, our healthcare team, managing our medications, and then attitude and support. So with exercise, there's that lovely quote, if you don't use it, you lose it. So exercise can manage symptoms and improve quality of life. Being sedentary and deconditioned can increase the stiffness, decrease our endurance, and cause a stooped posture. So typically we start to hunch like this when we're not exercising as much. The CDC recommends about 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise a week for older adults. And maintaining a regular routine is important to see those benefits. So we talked about the different kinds of exercise and what is good for Parkinson's. So there's the aerobics, so walking, running, cycling. Strengthening, so weights or your circuit training. Stretching daily, so a lot of people, before they even get out of bed in the morning, they'll complete their stretching while they're laying down, so that way they're able to kind of move a little bit safer and they're not bending down in a chair or trying to stand and do their stretching. And then for balance, Tai Chi is huge. We have quite the following in the Missouri area of our Tai Chi classes. Yoga and dance. And then we talked, someone asked about the diet considerations. So be aware that that some dietary proteins and irons can compete with the medication, so the carbidopa-levodopa. So as it kind of blocks it from crossing into our small intestines, making your medication less effective. So what's important to think about is when you're taking your medications, however your schedule is out for that day, you don't want to eat a large protein diet or meal right at that time, because that could keep your medication from absorbing into your body like it should. Constipation can be treated with plenty of fluids and particular foods and regular exercise. Keeping our body moving can keep our bowels moving. Low blood pressure can be treated with fluids and increasing your salt. So we talked about that orthostatic hypotension, so the dizziness upon sitting or upon standing. That's all your blood pressure changing. So that can be increasing your salt intake. Sometimes people will look at us and be like, well, typically a doctor tells me to decrease my salt, my blood pressure is off the charts. So that's really something to focus on talking with your doctor about and seeing where your blood pressure is, and maybe during the day, is it right after you took your medications? Did you not eat a full meal? And kind of figure out why your blood pressure might be all over the place. And then we talked about weight loss and how it can complicate PD, but it can also be a sign of other medical conditions. So talk to your doctor if you're experiencing that weight loss, whether it be your body's just not absorbing the nutrients it needs to, or maybe you need to increase your calories. So brain health may be enhanced by adherence to what they're calling the MIND diet. So this is basically going through, they've kind of blended the Mediterranean diet, as we've all heard of, and then the neurodegenerative delay diet. So we want to look at daily, we want to eat our whole grains, our leafy greens, and other vegetables. So those are going to be something that's really good for us. And then we want to cut back a little bit on some other things. So weekly, our nuts, our beans, our berries, chicken, turkey, fish, olive oil. So a lot of those are high in protein. So we're cutting back a little bit on those because of the medication absorption. And then unfortunately, at the bottom is all the good stuff that they want you to limit. So your red meats, your sweets and pastries, your fried foods, and your cheeses. They want to cut those out. All the good stuff. But that is the diet that they recommend for those with Parkinson's due to the calorie intake, the importance of medication absorption, and just overall health. So then we'll talk a little bit about our healthcare team. And this goes for everybody, not just Parkinson's, and how it's important to have all these people on our side and to advocate for ourselves and our health. So diagnosis and medical management would be your neurologist, your movement disorder specialist. So somebody might ask, what is a movement disorder specialist? That is a neurologist that has gone to more school and is educated specifically on movement disorders such as Parkinson's. So they have the neurology degree on top of another full degree that makes them more educated in Parkinson's, which also makes them more difficult to get into and see. But luckily here in St. Louis, we have a large portion of the movement disorder specialists, whether it be over here at St. Luke's or at Mercy or Wash U. We also want to look at our psychosocial support. So, we talked a little bit about depression and anxiety and all those things that come along with, just aging in general. So talking to a psychiatrist, having a social worker or a psychologist that can help you kind of navigate, or maybe you might need a little bit of some sort of medication to kind of help you through those anxious moments. So that would be who you would want to talk to for that. And then we talked a little bit about exercise and wellness. So finding those classes that we enjoy, working with our therapists. So we have our rehab teams up there, our PT, OT, and speech, that can help us get our maybe a home exercise program or something along those lines. And then just our general health. So we have our primary care physicians, our subspecialists, our nursing, typically it's a nursing assistant at our doctor's office, and then our nutritionist. Those are all people that you want to have on your team, kind of knowing what you're going through. And then this is kind of how we talk about communicating with our healthcare team. So before your appointments, we think it's very important to keep a diary or a log or notes of your symptoms. One week you might be feeling a certain way, and the next week that might not even be a problem anymore, but it could be long term. So we want to make sure we're talking about those things, writing those things down. And then any non-immediate questions. You go into your doctor, you might see them one time a year, but something happened 6 months ago and you're like, oh, I should ask them about this. And then we get to our doctor's office and they rush us through our appointment and we totally forget 5 out of the 7 questions we had. So if we have those written down, then we're not going to forget. We can check them off and make sure we're asking those questions while we're there face to face. And then during our appointments, you want to bring all those notes with you, any of your questions and concerns. Make sure you're thorough and concise. Make sure they're hearing you. Sometimes they just want to kind of rush you out the door. Maybe they're a little bit behind in their schedule, but making sure that they're taking the time and listening to what you're asking them. We also recommend bringing a family member, a caregiver, a loved one, somebody that can be a second set of ears, especially if you're newer to your diagnosis and it could be very overwhelming. You're trying to get all these questions answered and you're just not sure what to ask. Sometimes our brains just naturally kind of tune everything else out because we've just heard you have Parkinson's. Now what? So it's important to have somebody there as that second set of ears. And then making sure you're understanding everything that they're talking to you about, whether it be you're going to start your medication or you might need to alter your diet a little bit or try a different medication for your anxiety or something like that. You want to make sure that you're understanding what could come along with that. Maybe there's some potential side effects or you need to take this medication at a certain time of day. It's important to be able to remember all of those things. And then in between our appointments, if you have questions, make sure you're calling. Don't wait for your next appointment. Don't think, oh, I'm bothering them, they're busy. They're your provider, and it's so important that you access them. Typically, nowadays, everybody has access to their little portals, and you can ask questions directly on there. But if that's not for you, I know for me, I like to talk on the phone with somebody, so I call their office and leave a message, or I just keep calling until they answer my questions. So that's important because that's what they're there for. We talked a little bit about medication and our diet and how it's important to decrease our protein when we're taking our medication, but it's also important to take our PD medication on time within a 15-minute window as prescribed. So say you take your medication 3 or 4 times a day, you have a 15-minute window on each side to take that medication at that same time every day. Missing a dose can greatly affect our symptoms, especially later in the disease. So as we progress, missing those dosages, we'll start to see our symptoms kind of flare up a little bit more. We want to keep a record of all of our medications that we've been used to treat our Parkinson's, and that's not just your Parkinson's medications. That can be any medications that you might have that is a symptom of Parkinson's disease. We want to make sure that we keep those logged and that all of our doctors know that we're taking those medications. To go off of that, keeping a log will allow you to track the side effects, drug effectiveness, and possible food interactions. So maybe you take your medication in the morning and you eat a big breakfast with toast and eggs and some bacon, and you're like, I'm just not feeling like my medication did a lot, but then you go to lunch and you have a salad and suddenly your medication kicked in. Then typically you've eaten too much protein with your medication. But that's something that you can look at and talk to your doctor about. And then using timers and reminders is very important. We have our cell phones on us. Some of us have our watches, or you can just set a regular timer that reminds you to take your medications. Or we have Alexa who likes to yell at us and tell us to take our medications. And then with attitude and support, so as we know about with any disease or anything new to us, we go through kind of a phase of shock. How is this happening to me? What am I going to do next? What are my symptoms going to be? And then we go through a grief phase where we're sad, we're upset, we're mad, how am I going to handle this kind of phase? And then we have to kind of accept what's going on and take the next steps. So just knowing hope is critical. It's important to treat those sad, depressed states that we go through because that's part of human nature. We all go through it, whether it is something that's new to our lives or maybe it's something that's been going on for a while. You don't want to isolate yourself. Stay active. Keep talking to people, whether, I know here they're talking about the support groups and having people that understand what you're going through. But maintain a balance in life. Talk about your diagnosis. Some people are a little bit scared or timid to talk about it at first, but keep reaching out if you know somebody that has Parkinson's, or maybe they're newly diagnosed or they've had it for years. Check on them. Make sure they're okay. Make sure they're doing okay. If they just need somebody to listen or, need a little bit of extra help. Get educated and stay informed. Using support groups and counseling is important, and then getting involved to find a cure. So your network and support team. So we'll talk about friends, family, community, all you guys in this room. Spiritual guidance, whatever you might believe in or find that's helpful to you. Your healthcare team, so your doctors, your psychiatrists, your therapists, all of those special people. Whether you're in a support group or you're looking for a support group. And then us here at the American Parkinson's Disease Association that are available every day to kind of help you find what's next and what resources you might need. Maybe you just need to talk to somebody for a little while that kind of understands. That's what we're for. So we'll talk a little bit next. First, does anybody have any questions over what I went through? It's a lot. Okay. Yes, ma'am.
Is there any connection of people with Parkinson's and others in the family with restless leg?
Yes. So her question is there a relation between Parkinson's and others having restless leg syndrome? So many people with Parkinson's, because it is all muscle related, end up having RLS or restless leg syndrome. There is medications for that, but sometimes that can be difficult to kind of get through your day or as you're sitting or especially as you're laying down at night. So one thing we talk about that's really important with restless leg is making sure that you're exercising and moving your body, fatiguing those muscles throughout the day, so that way when you go to lay down at night, your body's ready to go to sleep. If we kind of sit around all day, we're not using those muscles, we're not fatiguing those muscles, so then we go to lay down and our body's ready to go. Now, as far as a connection, there's no medical connection with, if someone in your family has restless leg syndrome, that doesn't mean that that's connected to your Parkinson's. But it is a sign of, it's a symptom that comes along with Parkinson's. Yes, sir.
I think you said that about 1 million people have been diagnosed with Parkinson's. I suspect that the number of people that have Parkinson's is more like 50 million.
So that's a big thing, is that a lot of people, and that's what we're working on a lot too, is touching those people that are in those underserved areas. They don't know what their symptoms are, or they don't have access to the doctors. So if you think about how many areas of those in the United States that there are, and all of those people that don't have touch to a doctor, that aren't getting diagnosed, or maybe in some populations where a family kind of grows together. Grandma, grandpa is taken care of by their kids and then their grandkids, and that's just how kind of life works. But we don't get them to the doctor. Think of how many people are not diagnosed, or they're afraid to go get a diagnosis, or maybe there's a misdiagnosed. So I definitely agree that there's probably a large amount more to add to that number. But the numbers that they go off is basically just kind of with that map, kind of figuring out who in that area. So until the people reach out and look for their symptoms or want the help or are looking to figure out what's wrong, it's hard to find those set numbers. But I agree that number is probably way larger than that 1 million.
I don't think that's just the underserved areas. I think there's probably a whole lot of people here that have never been bothered to get diagnosed for Parkinson's.
Oh, I'm sure of that. I'm sure. And, typically people will say, oh, Parkinson's, that's the some people call it the old person disease, or that's that tremors. And people think, oh, just because I have a tremor doesn't mean I have Parkinson's, and so they don't get that looked at because that might be the only symptom they have. So I agree. I definitely think that it's important if you have that feeling, or and with that laundry list of symptoms as well, you think of how many other things go along with those symptoms that come with Parkinson's. Or later down the road, you're like, oh wow, I've had that for 10 years of my life, or I've had this for 5 years of my life. Maybe I should, reach out to a neurologist, but our primary doctors typically aren't looking for that. They're coming in, checking your vitals, making sure your blood pressure is good, and looking for diabetes, because that's a huge thing going on in the United States, where those are the basics. So that's where it comes into advocating for yourself and your caregiver, making sure that you're doing what you need to do to advocate for yourself as well. Is there any other questions before I? Yes, sir.
Listening to all the various symptoms, there are many other things that you have similar. For example, a concussion can give you double vision, can give you loss of balance. You have an operation on your heart and you can get blood pressures. All these things intertwine.
Mm-hmm.
And of course, when you get to be at the position of life that we're in, most of us have a lot of these things that have gone on.
Yeah.
So how to pinpoint without having to take dozens of medicine versus maybe one or two, or say, I'm done with it.
Right.
Let's just see what happens.
Right. Yeah, so what he said was that, typically the laundry list of symptoms that we went over, those can all kind of intertwine together. It could have been a concussion years ago, or something along those lines, to where how do we know that that's our Parkinson's, or how do we pinpoint exactly what that could be? So with that being said, that's where you kind of have to sit down with your doctor, and it can start with your primary doctor of, okay, well, I'm now having these tremors, or I'm now having this double vision, could this be? And kind of triggering those thoughts to them, because then as you sit down and you go through what symptoms you specifically go through every day, that could lead to, well, it is a Parkinson's diagnosis. Otherwise, it may not be a Parkinson's diagnosis. It's hard to tell, and I'm not a doctor to, sit there and pinpoint each thing, but at the end of the day, if you're noticing any of those symptoms, it's important to advocate and figure out what is causing those symptoms. Is it just because I had a concussion when I was 12 years old playing football with the boys, and now my vision is going bad because my eyes are getting older? Or is it deep down, is it something more? Is it Parkinson's? Is it something that this medication can help? And I know you mentioned taking 12, 13, 14 pills a day. Typically you go into your doctor and you add another symptom to them, and they just want to throw another medication at you. And that's where advocating for ourselves is so important, because you come in and you say, I don't want to take another medication. I want to figure out, is there something that could be an all-inclusive medication? Could it be something else that has made me to this point where I could cut out half of these medications by taking a Parkinson's medication because I finally have a diagnosis? Any other questions? Comments? Yes, ma'am?
Do you have any handouts to give us with the symptoms and everything on it like that?
So she asked about, do I have any handouts? So I did bring some handouts with me today of kind of what we provide at the APDA, and anything I can get over to Beth. So anything that we talked about today, I have a printout of the mind diet, I have a printout of the symptoms, I have a printout of neurologists and movement disorder specialists in this specific St. Louis area, otherwise Missouri in general. I can send all of those over for you. Absolutely. Yes, ma'am.
I was told that he was to have the medication at 8 o'clock, 1 o'clock, 6 o'clock. What happens during those hours during the night when that medication is not in the system?
Yeah, so typically when people get prescribed their medication throughout the day, pending symptoms, the doctor's thinking, oh, they're in bed all night, they're not going to need their medication at night. It's okay to have an off period at night because we're not getting up. But then you have to remember, how many times do we get up in the middle of the night to go to the bathroom? How many times do we need to get up because whatever it may be. It might be an emergency and we need to be able to get up and move. So that's where that extended release, if that's something that has become more difficult, where getting up in the middle of the night, maybe to go to the bathroom or whatever it may be, has become more difficult, you can talk to your doctor about that extended release, and that would be taken at your last dose. So most people take that around 7 o'clock at night, and that'll get them through the night to make it easier when you're trying to get up and move about throughout the middle of the evening. It really just depends on your dosage. Sometimes they'll space it out like that. If he's only taking it 3 times a day, you could potentially add another dose if needed and cut back a little bit depending on the on and off periods. But definitely something to reach out if that's something you're interested in. There is an extended release that can get you through the night. Yes, ma'am.
You mentioned about weight loss and problems if you're losing weight.
You talk about weight loss and problems if you're losing weight.
Mm-hmm.
If you are already heavy, do you suggest that someone lose weight, or maybe on the diet they would, or nearly?
Yeah. So there's a difference between, I might be a little bit overweight and I need to just, kind of get a little bit healthier. That's totally different than your body just naturally not absorbing the calories or just naturally losing the weight unplanned. So knowing the difference, if you've completely modified your diet and kind of started exercising, well then your body's probably going to lose a little bit of weight because you're going to lose that fat and put on muscle. But if it's something where you're not planning on it and you're noticing, wow, these pants are fitting a little bit looser, or wow, I didn't change anything and I'm looking a little bit thinner, that's going to be that weight loss that we're talking about. It's not going to be the planned, I chose to change my diet or I chose to start exercising and now I'm having a weight loss. That's something that typically comes along with that. So if you are starting to exercise, you can take that into consideration as I've completely changed my lifestyle, so I might be losing a little bit of weight, and that wouldn't be something I'd reach out to my doctor right away. But if it down the road, you've progressed with that same lifestyle and you're still continuing to lose the weight or, just not feeling so great, then that's where I would reach out.
But does it help if someone is thinner rather than fatter?
No, I mean,
is it, depends on the medication based on your body mass, or?
It doesn't. No, typically, we think about, we just want to be healthy. So, everybody's built differently. Some people are bigger boned, as they would say, or, they are just built bigger. So where your body's not going to absorb the medication differently. It's all based on your diet and your movement and exercise. So no, in answer to your question, it doesn't matter if you're, thin as a rail or if you're a little bit overweight. That's just looking at overall health in general, though. So if you're thinking about Parkinson's as a movement disorder, and I'm trying to, move my body around, and maybe I've been a little bit overweight, then you're going to look at the changes that might be helpful, but it's not going to affect the medications or the disease itself. Yes, sir. Oh, hold on, she's coming at you with the mic.
Okay. My question deals with the diagnosis. Based on what I have not heard, I am assuming that medicine is not able to detect through any test a drop in dopamine or the body-generated drug that controls all this. So there's no way to know from any test that that particular body drug is low. Is that right?
So what they will look at, typically the doctor does the overall exam, they kind of progress, and then they'll look at what they call a DAT scan. So it's a brain scan, and they can see that your levels are low. And that's where they monitor if the medications are working or not. Most people select to have a DAT scan. It's not something a doctor's just going to come at you and say, yep, you need a DAT scan, because it's not something that can diagnose Parkinson's. But if they do a DAT scan, they can come back later and realize that your dopamine is lower and the medication might not be working. Does that answer your question a little?
There's no test
Other than
Yeah,
that,
they can't
measure the blood.
Correct, exactly. There's no blood test, there's nothing. They are working on right now a skin biopsy, and they're working on a blood test is part of research right now, where they can look and see how much of a certain, whatever it is, I'm not a researcher, whatever is in our blood that they're looking for that shows the dopamine amounts in our body. But you can naturally make dopamine, being in the sunshine, laughing, exercising. Those are all things that naturally make us have dopamine. So that's kind of what we would consider like a natural upper. So that's why we talk about how important it is to keep our bodies moving, talk with our friends, laugh with our friends, watch funny movies, do all of those things, because you can naturally make the dopamine. This is where our brain just doesn't make it anymore. So it will slowly go away, but you can still increase. You can get those dopamine boosts by doing all of those things. Mm-hmm. Anyone else? Okay. Well, then we'll go on a little bit. I only have a few more slides. These are just more or less talking about the APDA and what we can provide and help you guys with. So at the APDA Missouri chapter, we have information about PD, so resources, referrals, anything along those lines. We do a bi-monthly newsletter that provides our schedules. It talks about different articles. It'll talk about the upcoming research they've done, any upcoming events we might have. We do a large symposium once a year where researchers come in. Dr. Perlmutter, who is one of the main movement disorder specialists over at WashU, he comes in. And Dr. Rebecca Gilbert, who is our chief medical officer of our national office, she comes in, she does a big presentation. So it's a lot of resources and education. We run about 50 plus exercise classes. I've actually added 3 more this week alone throughout the Missouri area. So we do some in person and some virtual. And then we have support groups as well. We do 30 plus per month, both in person and virtual. We just added 2 this week as well, starting off the new year, which is great. We run those both for people with Parkinson's, and then we run individual groups specifically for those caregivers as well. We have referrals to care providers and community services, whether it be you're looking for a new neurologist or you're looking for you need transportation or something along those lines. We have resources and referrals for that. We do small group programs. So we have a program called PRESS. It's an 8-week program for a person with Parkinson's and their caregiver. Right now we just run them virtually. We haven't gotten them back in person since COVID. But it seems to work better so that we can reach a broader population with that program. And each week that they meet, it's just in depth about a certain topic. We have Treble Clefs, which is our music group. They meet in St. Charles and they sing and work on their voice. We have our caregiver supports and more. And then we have our virtual resources. So we have webinars. I mentioned Dr. Rebecca Gilbert. She has a blog that's posted on our national office website, and then we also have access to that on our Missouri website. We have training courses and then publications. So any upcoming research and things like that, you can find all that information there. We have a YouTube page. So our YouTube is our exercise classes. So we host exercise in our office 4 days a week. And we record quite a few of our classes. Those get uploaded to our YouTube, and then you guys have access to those exercise classes any time of day or night that you'd like to get up and exercise. And they're listed by the type of class. So if that's something you're interested in, you all have access to that through YouTube or through our website, and I can get that over to you as well. And then we have our educational events. So I talked about our symposium. Our Midwest Congress is on April 11th of this year, of 2024, and that's going to be held at the Holiday Inn in Sunset Hills. And then we have our Parkinson's education program. So we host about 3 to 4 of those a year. Typically there's at least 2 of them right over here at the United Hebrew across from St. Luke's Hospital. And those are typically, we just have a topic. The last one was on medication and the importance of advocating for the medications we put in our body. The one before that was on mindfulness, so kind of finding that happiness and working through our daily lives. We also do a large event in May. We used to have a golf tournament. Now it's at Top Golf so that more people can participate. So this last year was our first one at Top Golf, and it was a hit. It was quite fun. And then we do our big walk in October, and Missouri actually holds the largest walk in the United States for the APDA. So the American Parkinson's Disease Association, we live by the mission of every day we provide the support, education, and research that will help everyone impacted by Parkinson's disease live life to the fullest. Do I have any more questions before I pass the mic along? And I'll be here afterwards too, so you can attack me before I leave. Well, it's been a pleasure. If you guys have any questions, I have my card here as well. I can leave my information. You guys can call me whenever. Again, I'm Kim, and it's been a pleasure.
To let everyone know as well, David brought these up, and it is a exercise classes for Parkinson's disease research studied by Wash U School of Medicine. So I'll have the flyers up here if anyone is interested. It says you will be paid up to $100 for participating. And then I also have some Parkinson's disease cards that if you do have Parkinson's and, for instance, get pulled over or something and you can't explain what's going on, you can give this card to the police officer or whoever it is that you're speaking with, and it explains that you have a neurological disease, you may slur your words, seem unsteady on your feet, and just to be patient, and then you would put your caregiver on the back of the card. And so it just kind of explains that you have Parkinson's. So if you're interested in either one of these, come see me afterwards. And then if you have any other questions, she'll be over here for some questions. Thank you.